All right, Beyond listeners, welcome to the Beyond podcast. I'm your host, Dr. Flora. As you all know, perimenopause, menopause, it is a hot topic where everyone has their 2, maybe 5 cents as far as opinions and supplements and things to do and things to not do. So we are here to bring science to you. Science-backed information in ways that you can feel empowered about your own health, whether you are going through this transition or not. It's important to be prepared and educated and know when to bring these questions up to your medical team. So I'm really excited to have my next guest here, Dr. Sabrina Sahni. She is a board-certified physician specializing in women's health and breast medicine. Dr. Sahni focuses her practice in the management of perimenopause and menopause in the general population, as well as in the high-risk breast cancer patients. There, she also plays an essential role in the management of new breast cancer diagnoses in her practice's breast cancer survivorship program. Hi, everyone. You are listening to Beyond, and I'm your host, Dr. Flora. Listen, life is hard. You don't have to do it alone. As a mindset coach, physician, mom, and an infertility warrior, I have mastered techniques to help move you towards contentment and growth. I can't wait to go along with this crazy-ass life journey with you while making sure you feel like your best self. This podcast is meant to have you feel unstuck from your rut and less alone. Let's do this. As a certified menopause practitioner, she has contributed extensively to women's health education through research publications and her social media presence, where she advocates for patient empowerment and awareness in perimenopause, menopause, breast health, and cancer care. Everything that we wanted to do today. So Dr. Sahni, Sabrina, thank you so much for being here. I'm so excited to deliver this wonderful information to everybody.
Thank you. Thank you so much for having me. I'm really excited.
Yeah. So again, as I said in the intro, I mean, this is such a hot topic. What are you hoping to teach our Beyond listeners today who are curious about perimenopause or menopause or going through the transition?
Exactly. And I mean, I think you stated it pretty eloquently. I think it's educating patients if you're going through it, if you are maybe anticipating it, even if you're a healthcare provider listening in and you don't know the data, right? If you're somebody who gets asked these questions all the time, I just hope that we have an appropriate evidence-based conversation about it. We start talking about these things because I think for so long women, and I think people in general have been pretty embarrassed to talk about menopause as, you know, I think it's been sort of deemed to be this sort of natural process, which it certainly is. But it doesn't mean we can't talk about the changes that occur during this period of time, because I'll tell you, it does not only affect the woman, it affects her entire social circle, her familial relationships, her job relationships. And so truly everyone is affected.
Yeah, that's such a good point. Why do you think menopause is such a taboo topic, not only within our society, but in healthcare settings?
I mean, it's no surprise. I think women's health has been undervalued, underfunded, under-researched. You know, it took until 1993 to even have women be involved in clinical trials. So I think in the context of medical research, women have been sort of marginalized in that regard. And I think as a result of that, there's been a huge lack of education amongst the population and certainly amongst healthcare providers. So we just didn't learn about it.
Yeah, I think that's such a good point when you say we're not, as medical providers, we're not prepared. I don't know about you, but I got like maybe 5 minutes of like, this is what marks women into menopause, right? I mean, we didn't really get the nitty-gritty. I mean, we also didn't have very much data behind this whole transition period. So that being said, let's go over the basics. Like, let's go, we have all these words being thrown around. Let's go over basic definitions. Premenopause versus perimenopause versus menopause versus postmenopause.
Right. Okay. So premenopause is basically any woman that's getting normal monthly cycles, they're ovulating regularly, and they're essentially asymptomatic. So all of those sort of like classic menopausal symptoms you hear about, the hot flashes, night sweats, sleep issues, those have not started. Okay.
So we're talking about the point in time where a woman starts their period onwards. They're getting regular periods
Correct.
or whatever. They're menstruating, whatever their regular
Correct.
may be. Okay.
Correct. Yep. Perimenopause is sort of that transition period into menopause where things start to change and women start to say, hey, you know what? I'm noticing some changes in my periods. And that's usually the first symptom or the first thing a woman will sort of notice, whether it's lighter periods, heavier periods, further apart, closer together, but there's just some change from their baseline.
Mm-hmm.
Unfortunately, the perimenopausal transition is not only the most symptomatic time for women, but it can last up to 7 to 10 years. So if you think about menopause in general, like a lot of these symptoms could be fair game in a woman in their late 30s, right? And
Yes.
certainly, unfortunately, once you hit 40, we say, okay, some of this could be really, perimenopausal changes.
Yeah. With perimenopause, so we know that we can't diagnose it, but
Correct.
what if you had mentioned perimenopause being any change, right, within your periods? What if someone doesn't have a regular period
At
at baseline?
baseline? Okay, so if they came to me, they weren't having regular periods, or say they had a hysterectomy at a young age for
Mm-hmm.
whatever reason, or they had an IUD in place, so they just aren't having regular periods. But let's say they're having some of the other symptoms, maybe
Okay.
hot flashes, mood changes, joint pain, hair thinning, skin changes, vaginal dryness. I mean, we can go, there's,
Well, we'll definitely
hundreds.
hit that.
Yeah.
Yes. Yes.
um, that is a time where I may do blood work to
Okay.
determine, but even in that setting, it's a clinical diagnosis. So if you
Yes.
came to me with all of these symptoms, I'd say, yeah, this sounds like perimenopause. And sometimes I use it to sort of confirm, but the thing is when you check blood work, right? Especially when you're perimenopausal, it's a snapshot in time. So today it
Yes.
could look different. 5 days later, it's going to look completely different as well. So I think that that's sort of a hot topic right now too, amongst a lot of people trying to get into the menopause space of checking blood work, checking saliva, saliva
Yeah.
estrogen levels, urinary estrogen levels. And, I don't necessarily know that they're the most reliable indicators of
Yeah. We'll
menopause and
also get
perimenopause.
into that nitty gritty too
Yeah.
of what to do, what not to do. Okay.
Yeah.
Let's continue with the definition. So, menopause, what is the definition of menopause?
So menopause is essentially 12 consecutive months without a menstrual cycle. While you're sort of having some of those symptoms, natural age of menopause is about 51 and a half. But again, I've seen it happen earlier. And again, we have to, especially if it's occurring early, we got to rule out other causes, right? Is there another chronic condition that could be causing it? But it's really that 12 consecutive months without a menstrual cycle.
And postmenopause.
Everything after. Truly everything after and beyond.
Okay, so just to review,
Yes.
premenopause is in your reproductive years as a woman, you're having consistent, semi-consistent ovulation, menses, no symptoms.
Right.
Perimenopause is that transitional period up to 10 years prior to menopause, and
Yep.
that could present with a multitude of symptoms. That also includes irregular periods, hot
Yep.
flashes, insomnia, night sweats. We'll go over all the other details. Menopause. So you hit
Yep.
menopause after you haven't had a period in 12 consecutive months.
Yep.
It's like that point in time where where it's
Yep.
like it's like a time period, right? Like you
Yep.
don't, it's not a transition period of time. It's like a single point in time where you're like, all
Yeah,
right,
it's like a hard stop.
ovaries are done.
Yep.
Yes.
Yep.
And then postmenopause is your life afterwards. Yay.
Yes, exactly.
So let's go into the perimenopause. I feel like
Yeah.
that is the most confusing for so many of us. I'm 40 and I personally started having perimenopausal symptoms last year at 39. And
Mhm.
in my head, I thought I was going crazy. I'm grateful to be in the medical field because I had a lot of contacts, but I thought I was dying. Like I didn't know what was going on. And I had a full workup, almost head to toe, because I had head to toe symptoms. And that included a sudden onset of hot flashes, night sweats, anxiety, depression,
Yeah.
joint aches and stiffness, palpitations, severe gut issues. And when I
Yeah.
say gut issues, anywhere from like, I haven't pooped in like a week to
Yeah.
all of a sudden, like I'm having diarrhea and I don't know what's going on. And
Yeah.
for me, I have a pretty strict lifestyle when it comes to good nutrition and good exercise habits with strength training, cardio, and so on and so forth. I thought I was going nuts, literally. And
Yeah.
that's when I started looking into perimenopause, menopause, and like it just clicked. I'm like,
Yeah. I know.
but so
And
many women say to themselves, like, I'm in my 30s. I shouldn't be doing this.
correct. And truthfully, it's fair game. I mean, think about it.
Yeah,
Like if a woman goes into menopause and has her final menstrual period at 46, she could start getting symptoms as early as 36, 37 years old. I mean,
absolutely.
that's, and to your point, it's incredibly confusing, right? I don't think a lot of people know to sort of like connect the dots because so many
Yeah.
things are happening. I mean, depression and anxiety is like rampant during this time period, right? And you think about like
Yeah.
the different periods of time where a woman would experience mood changes. It's like, puberty,
Yes.
postpartum, and perimenopause and menopause. So like, of course there's a hormonal influence in that, right? Because those are the three biggest time periods in a woman's life where like hormones are sort of erratic or changing
Yes.
or up and down. And I think from a clinician standpoint, and understandably, right? If a woman comes in with palpitations, like your first thought isn't probably going to be perimenopause, menopause. Maybe it should be in your top three, but a lot of times we got to do our due diligence and rule out, a cardiac issue or,
Yes.
check out some of the other stuff. But I think it's easy for providers to be like, well, your cardiac workup was negative. This was negative. This was negative. Like it'll probably just, resolve. Maybe cut back the
Yeah.
caffeine or do this or let me
I
know
said
how it's
that to
going.
myself, Sabrina. I
Yeah.
was like, EKG's fine, Zyopatch is fine, my
Yeah.
electrolytes, vitamin D, B12, all
Yeah.
that's fine. I drink 1 cup of coffee. I gave up coffee. And then I'm like, maybe I shouldn't be doing cardio because maybe something's like in my head. I just spiraled. But you're
Yeah.
right. Perimenopause is a diagnosis of exclusion, I think, because we
Yeah.
do have to rule
Totally.
out a lot of objective data. And if someone
Correct.
is just coming to us as a patient with a single symptom, uh,
Hmm.
we do have to rule out other
Yeah. Other stuff.
signs.
Yep.
Yeah, absolutely. So what are the earliest signs of perimenopause that most women and clinicians, I guess, frankly, that they miss, and how can we better prepare? I think perimenopause is like puberty in reverse. That's kind of how I describe it to my
Yeah.
own patients. It sucks. So
Yeah.
what are the earliest signs we should look for, and how can we better prepare for it?
So the problem is perimenopause, even though it's a very symptomatic time, like your symptoms can come and go. You might be fine for a month or two, and then for 2 or 3 cycles, you're sort of all over the place. Your mood is changing, your sleep is changing. So I would say, like, track your symptoms. That's like the number one thing a woman can do. And I know that seems like tedious. You don't necessarily have to write it down. I mean, we're all digital. I've had patients coming in like with
Yeah.
an app on their phone or in their notes tab being like, hey, you know what? My October cycle was this. My December cycle was this. I'm feeling great now. But like, I don't know. I just felt really off during those periods of time.
Yeah.
And I think the one thing that, women should do to prepare is to talk about it, right? I mean, like we are starting to normalize the conversation. I work in this population, right? So I do counsel. Even if a patient comes in, she's premenopausal, for example, I'll say, you know what, like, in the next couple of years, things may start to change. This is what to
Yeah.
look out for. If things start to change and you're worried, let me know and we can talk more about it. And that comes from the provider education standpoint where we
Yes.
really just need to do so much more to sort of prepare women for this time period. OBGYNs and doctors do a great job preparing people for pregnancy, right?
Mm-hmm.
And what to expect in the postpartum period. But after that, it's sort of like, all right, well, you're good, right?
Mm-hmm.
See you later. And it's
Yeah.
really unfortunate.
Yeah, you're
Really
right.
unfortunate. I
You're
mean,
absolutely right. I mean, even the postpartum, right? They call that the fourth trimester, where
yeah,
you mentioned earlier, you alluded to it, that these hormonal changes are really rough on
yeah,
physically and mentally for a lot of women.
yeah.
And many of us weren't and aren't prepared for it, or we're not educated about it.
Correct, correct. And like you sort of like everybody chalks it up to the hormones, right? You just chalk it up to, oh, my hormones are all over the place. But like, there are things you can do. There are solutions. I mean, even just
Yeah.
talking about it can sometimes help where you feel like somebody else has also experienced the same thing, right? Like
Yeah.
there's strength in numbers. And so I think, hopefully we're moving the needle a little bit more on that. But yeah, it can be a really confusing time period. Certainly from like even my background, for example. So I did family medicine. I know you alluded to that earlier, but
Mhm.
In my residency, I had so many women coming to me in this like perimenopausal, menopausal time period with like mood changes or sleep issues. And like, this is nothing against anybody that's taught me anything, right? We just didn't have the education, but like, I refuse to accept the fact that all of these women just have to go on an antidepressant when they hit 45, right?
Yeah.
And I think I almost like didn't accept it for myself, right? I was like, I don't want this to happen to me. Is this what I'm going to feel like when I'm, in my late 40s? There's got to be more we can do. And so it was sort of at that point in my first year of residency where I was like, I got to look into more of this women's health stuff. And then I, found the fellowship and did all this stuff. But I mean, I didn't even want it for me. I don't want it for me, right? Like I don't want it for
Right.
anybody else, right? And to your point, what otherwise is never talked about.
Yeah,
Right?
you're completely right. And I think both of us being in primary care, our job is to prevent. Right?
Correct.
Yes, we diagnose, yes, we treat, but most of our passions lie within prevention. So whenever, similar to you, whenever I'm counseling patients, especially my female patients, about preventing future medical issues, I always pose it as, what you're doing now, whether you're in your 20s or 50s and so on, you're preparing yourself for, for me, for example, I'm prepping myself for the 50-year-old Flora. And I
Correct.
want to stay functional, mobile, and happy and healthy, right? Those are
Correct.
like simple goals that even though now there are definite benefits to all the lifestyle changes that we normally coach patients on, and especially our perimenopausal, menopausal patients, but we're working to prevent all the crap that's going to happen as we age. And we go through, as women, we go through the largest change in a smallest period of time. And we'll go into kind of our, potential health issues that could come up or that we are at risk for as our estrogen decreases. So along the same lines, what are the biggest myths about menopause, perimenopause that really drive you crazy?
There are many. It could probably be its own podcast episode, like in and of itself. I would say my biggest thing is that hormone therapy is dangerous. I mean, like, the Women's Health Initiative, and, we may get into this at some point, it really did nobody any favors, to be honest with you. It was a flawed study, in my opinion. I think it was misinterpreted in the media, and I think it scared women away from being on hormones when here we are, 20 some years later, actually being like, hold on a second. You know what? Maybe it didn't increase cancer risk, or maybe it didn't cause cardiac issues. Maybe it was actually somewhat protective against cardiac disease. So, I mean, I would say that is probably my biggest, gripe with everything, is like trying to sort of like undo a lot of what has been done in the last 20 years. And, and I think that's also tying into like why women don't want to talk about it, right? Like you're like, well, there's no treatment option, or there's nothing I can take because, hormones cause cancer. So like, this is just a period of life. Like I'll just get through it. Right.
Or the understanding that this is normal. Like we just have to suffer and go through this because there is no treatment. So let's rewind a little bit. The WHI report study. I don't know if it's possible, but let's just briefly talk about it, about what it was testing, who it was testing, and what it actually found and how it was misinterpreted, just so our listeners can understand where all of this fear mongering stemmed from.
Okay. So Women's Health Initiative came out or started in the early 1990s. It took postmenopausal women, I believe, age 50 to 79, and it basically gave them, there was a different arm. There was an estrogen progesterone arm, so women that had an intact uterus that had to take estrogen and progesterone together, versus an estrogen-only arm, so women that had had a hysterectomy that could take estrogen alone. What their primary outcome was cardiovascular risk and breast cancer. And their secondary outcomes were fracture risk and quality of life and symptom management. So number one thing is we would never give somebody menopausal hormone therapy to prevent chronic disease, right? So like their primary endpoint was already flawed, right?
Yeah.
Then it was abruptly stopped in the early 2000s because of fear of increased cardiovascular risk and increased risk for breast cancer. And basically everybody was stripped of their hormones. They went out in the media and said these things could potentially kill you. And for 25 years, nobody ever talked about hormones, right? Nobody ever said anything about it. And to your point, you and I were sort of in med school at this time period where like, we had 2 slides. It was like, what is menopause? And a summary finding of the WHI, and it can cause cancer. So like, move on, right? And that's how we were all put into practice. And now, as a lot of new emerging data is coming out, like some of the flaws with that study was, one, the average age of women in that study was 63. So like
Yeah.
much older than when we would ever initiate somebody on hormone therapy. And we'll talk about this at some point too, but like there's this timing hypothesis, right? Where like if you prescribe hormone therapy early, so within 10 years of a woman's final menstrual period or under the age of 60, generally the benefits outweigh the risks, to be honest. The formulations that were used are not commonly used today, right? So those were conjugated estrogens with synthetic progesterone or just the conjugated estrogen alone. I think there's a time and a place for conjugated estrogen. I'll say that. I know there's a whole bioidentical world out there that may beg to differ, but I think there's a time and a place for it. But oftentimes those regimens aren't used in current practice. So it's hard to sort of like compare apples to oranges on that, right? The other thing was, I am a strong believer that correlation does not equal causation, right?
Oh, yes.
So like while there might be a correlation with certain medications, and again, any medication you take, right, probably has a correlation with some sort of chronic disease to some degree, right? Like long-term use of NSAIDs could increase your risk for a GI bleed and gastric ulcers down the line, right? But nobody talks about or nobody puts a black box warning on,
correct.
Like ibuprofen or Motrin saying like, this is what to do, right?
Yeah.
Or this is what it can cause. So, and so many women in that study like didn't account for the fact that they already had cardiovascular risk factors. They probably already had obesity. They already had underlying, hypertension. Family history of breast cancer, right? I mean, there's so many things that like when we think about chronic disease risk in the setting of medicine, it's never just one thing that causes it, right? It's multifactorial. It's usually a cause of many things. And I think in medical research, it's pretty hard to sort of like have a really good study that takes away all of that noise. I mean, we do the best we can, but I think in this study, we've created a large generalization and stigma over something that was truthfully pretty poorly done, in my opinion.
Yes. Thank you for spelling that out. So the study already targeted older patients on average, and it didn't account for pre-existing risk factors that obviously could increase a patient's risk for cardiovascular disease. That means heart attack, stroke, breast cancer, and you mentioned bone thinning, so osteoporosis. And then another thing was they used medications that really isn't meant for widespread use at this point in time. You said there's a time and place. Medicine is a tailored practice, right? We take a look at the patient. We don't have to do everything by a textbook because patients don't follow the textbook. And so you're right. There is a time and place for conjugated medication, but as far as a generalized treatment plan.
Correct.
So there's so many issues with these studies. And then you're right. They went to the media, and the media, I think, I kind of remember this where, I mean, these are scary headlines, right? You take hormone therapy and you will have heart disease. You take hormone therapy and you will be diagnosed with breast cancer.
I know.
Like those are things that are life-changing diagnoses, life-threatening diagnoses. So I understand the fear. I remember being in residency and we were learning how to interpret a lot of these, large research studies. And the Women Health Initiative was one of them. And I specifically remember my program director at that time, he was like, you need to read through this and tell me why it's flawed. So I learned in residency, this was after undergrad, 4 years of medical school, that it clicked, that I'm like, wait, hold on, hormone therapy may have a place. But again, we didn't have data back then. I mean, I feel like I'm so old, but it really wasn't that long ago. About a decade ago, right? Where, we still didn't have very much data. And even now, I mean, there are smaller studies that are pointing us in the right direction. And I think hopefully, 10 years down the road, we'll have these larger, hopefully RCTs that will help us gauge what to do from a more formulaic standpoint. Okay, so thank you for going through that. Anything else that drives you crazy? I know the supplement realm is huge, and
it's
also
huge across the board.
Yeah,
like across the board. I mean, certainly, I think the wellness industry does a really good job on preying on vulnerable women who are just looking for answers. I mean,
Yes,
they're just
I
looking
was
for
one of
answers.
them. Yes.
Oh my God,
And
how many things I
I'm
bought off Instagram because I've been targeted and I
yes.
buy all these things
Yes.
for like $60 or $70 a pop?
Yes, when you are
Yeah,
not feeling well, and this is coming from a person that is medically trained, that
yeah,
is a menopause certified practitioner, again, after the
yeah,
fact, after I started having symptoms, but
yeah,
you're in this mindset where you're just like, give me anything to feel better. And if modern
correct.
medicine doesn't have an option, I am happy to go to alternative medicine as long as
Yeah,
it works for me. And so
correct.
I understand, I think all of us can empathize when a patient is struggling and they don't know what to do,
Yeah,
and they are buying these supplements which may or may not be harmful, right? We also don't have too much data behind a lot of these
correct.
off-label, non-FDA approved
Like over the counter stuff,
over the
right?
counter
Yeah,
medication. So we went through why hormone therapy is unfairly demonized because of a lot of the flaws in those studies, how media kind of spread the message or the incorrect message. Let's chat about treatment. First and foremost, let's put a hold on the hormone therapy talk.
sure.
What can women do, regardless of what stage of their fertility or menopausal stage they're at? What can we do from a lifestyle standpoint that we have control over to help
Hmm.
us prepare and deal with these changes?
I think you said it perfectly earlier. Like what we do now has a huge impact on what's to come, right? So implementing things like healthy lifestyle habits, so exercising regularly. And again, like it doesn't have to be like you go to a bunch of like HIIT classes or cardio
Yeah.
classes or, do anything crazy. It's just something where you're actively moving your body, right?
Mhm.
In the same vein, you mentioned like, oh, do I need to do cardio? Do I need to do weights? Do I need to do this? Do I need to do this? Like, there's so much misinformation on social media and in the
Yeah.
news. A woman probably doesn't know where to even start, right?
Yeah.
Start by just moving your body. Like, go
Yeah.
for a walk for 20 minutes. Just start there and build off that, right? I say what the best exercise is the one that you're actually going to do consistently. So
Correct.
if you are somebody that loves group fitness and goes to HIIT classes and does that, by all means continue to do it, right? And I think you and I are the same. We love like sort of that like high intensity stuff, but again, sometimes I love a good yoga. And I
Mhm.
think there's a lot of emerging data on resistance training and strength training, on metabolic
Mhm.
health, on cancer risk recurrence, on cancer reductions. So
Mhm.
I really tell women, go lift weights. Lift
Lift heavy
weights.
shit, and it works.
Yeah, it works. It works. And even if you, let's say, don't have access to a gym, I mean, like you can go on YouTube. You can even do yoga or Pilates where
Mhm.
you're using your body weight as resistance. Like
Yes.
that is super helpful for your bones. That is super helpful
Yes.
for your metabolic health. So again, it doesn't have to be this grand endeavor. Just start small, right? And then diet, right? Again, you could have a whole podcast on what to eat, what not to eat, but I think like ultimately, as long as 80% of our diet is pretty healthy with fruits, vegetables, whole grains, like limiting processed foods, that is going to set you up for success down the line. And
Yeah.
then I'll make a caveat about this. I mean, alcohol. Like we've seen it in the news. We've known about this despite the fact that it hasn't been talked about. But alcohol can cause pretty significant impacts down the line. So,
Mhm.
while we all probably enjoyed drinks heavily in college, some of us maybe not.
Yeah.
I mean, some of that adds up, right? Like,
Yeah.
and I'm not saying people shouldn't drink alcohol. I'm just saying we should be really mindful of it, truthfully. We really, really should. From a cancer perspective, at least what I tell my patients, like, at least in the setting of breast cancer, the gold standard or the message we say is like less than 7 glasses per week, so less than a glass a day. Truthfully, that risk starts to go up by glass 3. So I say if you really want to be
Okay.
diligent, like keep it less than 3 glasses per week. And again, that's an average, right? You might go a month without drinking alcohol. You might go on vacation and drink every night, right?
Sure.
So, I would say a healthy balance of that. But I think those are really big things. Sleep. Sleep is also
Oh,
another huge hot topic. We
yeah.
all love sleep. I love sleep. You love
Hmm.
sleep. I mean, it
Hmm.
needs to be a priority.
Mm-hmm. That
Yeah.
was a wonderful breakdown. Sleep, exercise, and nutrition. I'd love to delve in just a tad
Yeah.
because you're right. These are hot topics, and there's a lot of information, and it can get really confusing and
Yeah.
overwhelming. And from like a mindset coach standpoint, I tell patients, I coach my clients on habit building. That's
Yeah.
huge, but I also counsel my patients on habit building. So after this whole appointment where I'm talking about sleep and
Yeah.
nutrition and exercise and hydration and all this stuff, I kind of see this like deer in headlights look, and they're like, where do I start? So I
Yeah.
always tell my patients and my clients, this is not a tomorrow goal. This is like
Correct.
a 1 to 2 year goal setting exercise. So pick one
Yeah.
thing. If it's,
Yeah.
I don't know, drinking water. If you drink maybe 8 ounces of water, which I think I can finish within like one sitting, start monitoring it. What is your goal?
Yeah.
Start increasing it to the point where you're hydrating appropriately, not
Correct.
going crazy where you're waking up in the middle of the night going to go pee every 5 seconds, but where you're hydrating. Or even if it's exercise, you mentioned just simply going on a walk, which
Mm-hmm.
is so important. Sitting is like the new death sentence,
I
right?
know.
And
I was just
so
going to say that. Yeah.
yeah, and another thing is, the 10,000 steps, and we all know that that was more of a marketing ploy versus
Yeah.
anything else. But clinically, being sedentary means sitting for longer than 90 minutes at a time and taking less than 5,000 steps a day.
Yeah.
5,000 steps a day, that's like a 30-minute walk. And you can break that
Yeah.
up into multiple
Yeah.
periods of time. Go to the grocery store. If you're running errands, park a little farther.
Well, further.
Go
Totally.
upstairs. These little steps. I mean, you can
Yep.
work on just this one goal for a month, right?
Yeah.
And then build on that once things
Yeah.
become a little routine. When you try to do all the things all the time, all at once,
It's
that's
not
where
going to
we fail.
work.
No, that's where
Yeah.
we
It's
fail
not
on our
going to work.
habits. And that's where we're
Yeah.
like, and then we also go in with an all or nothing mindset, right?
Correct.
Like I recently had a sinus infection. So I'm like using myself as a recent example, but I couldn't do yoga. I couldn't lift
Yeah.
because anytime I would turn my head, my face felt like it was going to explode. So I went out for walks. Like I could still
Yeah.
move. No, it's
Yep.
not part of like my regular regimen, but it's still better than nothing.
Totally.
And so I think it's important to kind of switch our mindsets a little bit when it comes to how to approach these good habits and give yourself time,
Yeah.
patience,
Yeah.
grace, have backup
Mhm.
plans, because our day-to-day life is they're going to continue throwing us curveballs. If we go on vacation, we don't have to let go of all of our habits, right? We can
Correct.
still go on walks. We can still
Correct.
drink in moderation. We can
Correct.
still
Yeah.
choose a salad and then a protein. I mean, we have options.
Yeah.
And so
Yeah.
it's just taking those small steps. And this is work that I'm sure me and you have been building on over many, many years. So I always try to use that as an example and try to let patients know that it doesn't happen yesterday.
Totally. And I think we live in a culture where we all want an immediate fix. Everyone just wants something to change in the snap of a finger. And I'm guilty of it too, right?
Absolutely.
Like I want to do all of the things all of the time. And, if I'm on vacation and I'm out of my routine, like the first thing I want to do is do all of it when I get home. And then I crash like 72 hours later, right? Like
100%.
you just have to do one thing at a time and be okay with that. It's the long game. We're all playing the long game here.
Yes. The 10-year older version of yourself is what you're working towards. I love that. And then you had mentioned nutrition, same concept. I mean, I know protein is this huge thing, which is still very important. It's important to get enough protein. Many of us don't get enough protein, fruits and vegetables.
It's hard.
It is difficult.
It's hard.
But speaking from personal experience, I worked on my nutrition for almost 2 years. 2 years. I mean, that took a long time. Patients pivot, and I had to pivot if something didn't work out. Finally, I'm at a point where I can find a source of protein comfortably without overthinking, without using too much brain energy. So I know it's possible. We just have to be patient.
I always joke with my girlfriends that like counting my protein goal is like a day. It's like a full-time job. Like I need to quit my current job because like I have to devote my time to like how much protein I'm taking in. Right?
You
like
are absolutely right.
It's a huge topic, and like it's impossible to get in. It's seemingly impossible to get in, right?
Yeah. And it has to happen gradually because again, on the flip side, if you increase your protein from nothing to 100 grams, you're going to get constipated. And guess what?
Yep.
That doesn't feel so good either.
It's not fun. Not
And so
fun.
all these little things, I think it's great to build on these small habits and put your blinders on when you're on social media. That's another piece of
Yeah.
advice I would give to our listeners. There's a lot of information on social media, but pick maybe one or two. Maybe you pick Dr. Sahni, you guys, and follow
Yeah.
her on, when it comes to getting advice about this transition period, about nutrition, about exercise. Pick one or two reputable sources and
Yeah.
follow them. And that
Yeah.
way you're not getting bombarded with all of this information, some of it misinformation, and then that
Yeah.
causes confusion and this feeling of overwhelm, and then people just don't do it.
Yeah.
It's
Yeah.
human nature.
Totally. It is.
Okay.
It really is.
Sorry, we went on a little bit of a detour,
Yeah.
but let's go back to
We'll bring it back.
we'll bring it back. Let's go back to perimenopause, menopause. So it's more than just hot flashes and night sweats. What other
Correct.
symptoms can patients present with, and how does it physically affect us? You mentioned cardiovascular health, our brain health,
Yeah.
bone health. What else does it hit?
So the best way I describe it when a woman comes in with maybe a hot flash or a night sweat, or they are talking about irregular periods, I say you've got estrogen receptors from your head to your toes. So we're talking sleep issues, mood changes, hair changes, skin changes, joint pain. I mean, there's receptors in our cartilage, ligaments, and our joints. It changes your metabolic function. So that central adiposity that likes to, work its way in, and your mid 40s to late 40s, that's the thing. Vaginal dryness, low libido, recurrent UTIs, and just a general feeling of not feeling like yourself. I mean, and I've told patients, sometimes that's just, it's okay if you're you know what, I just don't know what it is, but I just don't feel like myself, right? And that can sometimes just be a symptom, right? So it's more than just hot flashes and night sweats, despite the fact that affects about 75 to 80% of all, women. But I've also had patients that have come into my office that have not had a single hot flash, and their biggest thing is joint pain, right?
Yeah.
And they've seen ortho, they're about to go to the OR for surgery, and then we talk about it, and they go on low dose estrogen, and they're like, I am a new person.
You actually recently mentioned that on your social media, on your Instagram page, that a patient was about to go to surgery.
It was like magic. Yeah, she literally was about to go to the OR, and I felt kind of bad. I sent a note to the ortho, but I was like, you know what? Maybe we can just clinically follow, see how her symptoms are doing. She's doing much better, and she was like, I can exercise again. I can go out and do the things I want to do. My quality of life is improved, and so sometimes you don't even realize what that symptom is, but it is correlated to perimenopause, right? So I think tracking whatever feels different is incredibly important. And when you do get a chance to talk to your doctor, mention some of these things, right? Especially if you're trying to find something that connects all the dots.
Right. I think it is important to keep the lines of communication open. I love your idea of tracking your symptoms, because sometimes they're all over the place and they're not consistent. They may not be related to your cycles. They may be. I mean, I've seen kind of a huge spectrum of presentations when patients come, and they feel all over the place because they physically are all over the place. There's a lot. And you mentioned there's transmitters all over our body. So, brain fog and memory loss or trouble with memory, all of that makes sense.
Totally. Right. And to kind of segue into your other questions, I mean, things that occur after menopause, right? A huge increased risk for cardiovascular disease and risk factors. So hypertension, high cholesterol can occur when a woman goes into menopause, right? There's cognitive decline that can occur, and then there's bone loss, right? So from a bone perspective, women lose about 1% to 2% of bone in the first 5 years of menopause, and they can lose up to 20%, right? That's huge. And to your point of what do you do when you're young to build on it, it's like a bank, right? The more you do now, the more vitamin D, the more exercise, the more you take care of your bones now through healthy living, the less it's going to affect you when you're going through that menopause transition, right? You want to store a lot in the bank today so that when it eventually has to come down, you're not dropping rapidly and having really, really brittle bones, right? I mean, osteoporosis in general, I think, is incredibly overlooked. The 1 year mortality from a hip fracture has been quoted up to 30%.
Yeah,
I mean, that's insane.
It's kind of crazy. It's crazy.
It's insane. So, I mean, that's a huge thing that I tell women, especially my young patients, get on vitamin D, exercise, like you said, lift heavy, right? You don't have to be a bodybuilder, but go do something that's different, right? Try something different. This will all have huge impacts down the line in terms of your chronic health. And then brain health and cardiovascular risk, right? So, I mean, these are huge, huge topics, right? And if you want my honest opinion, I think estrogen is probably not only cardioprotective, but probably neuroprotective as well. And I think if you utilize things like hormone therapy early, it can really help you down the line in terms of your lipid profile. I mean, this hasn't necessarily been proven, but from like an Alzheimer's perspective, I mean, I
Yeah,
think
I've heard of that.
the data is sort of telling that there might be a lot of like neuroprotective effects. I think Dr. Lisa Mosconi's book, The Menopause Brain, and
Yeah.
her recent articles about, estrogen receptors in the brain and all of that metabolic slowdown when the estrogen isn't able to bind to those receptors, how it causes the memory loss, the brain fog, the cognitive changes, and that could lead to an increased risk of cognitive, dementia down the line. So I think there's a lot that we still need to learn about, but I do think we definitely see the benefits of estrogen from a chronic disease perspective.
Yeah, I mean,
It's there.
it is there. And
It's
again,
there.
data is small, so I don't think we're going to hear these generalized recommendations yet. I think they're
Correct.
coming, though. They're coming. There's more and
I
more data
do.
that's building.
Correct. I mean, I think from the cognitive perspective, there's the KEEPS trial that came out, I think, in 2016 or 2017 that looked at like early initiation of hormone therapy and cognitive risk and cardiovascular risk. Cognitive risk actually didn't show any, decrease in risk of dementia if you were prescribed hormone therapy early. But I think we're now 2025. We're seeing a lot of changes, a lot of new things that we're learning about. Where, to your point, I think it's probably coming. I think it's
Yeah.
probably coming. And then KEEPS trial also looked at cardiovascular profile as well, and that definitely showed improvement in metabolic and lipid factors. The PEPI trial also showed
Oh, yeah.
similar improvements in HDL across the board, regardless of what formulation. So estrogen alone, estrogen plus progesterone. There's this whole idea of other progesterones that we're using and whether or not certain progesterones have different influences on cardiovascular risk and bone health and all of that. There's a lot we're learning about, and all of that to say, like, perimenopause and menopause, treatment is not a one size fit all. Just because your girlfriend goes on this doesn't mean that's what you should be going on, right? Like sometimes I do reach for a non-hormonal for a patient. Sometimes I do reach for a combined estrogen progesterone pill versus a patch and oral progesterone. I mean, everybody's different. It's based off your lifestyle, what you need, what you're feeling, and all of that. So not a one
Absolutely.
size fit all.
Never. It never is. You had
Yeah.
mentioned earlier in the episode that after 10 years or above the age of 60, the risk actually of being on hormone therapy goes up. Can you break that down briefly for us?
So I'll say initiating later definitely increases the risk for cardiovascular disease, dementia, and other mortality. I think when we think about it from a cardiovascular perspective, if initiated early, usually it promotes vasodilation, it slows atherosclerosis. Again, if you're 60 and you already have developed atherosclerosis and I've put you on estrogen, it's likely that it might break some of that out and cause an issue. I say if you prescribe it early, there's no definitive timeline of when you need to stop, right? Usually, 60 to 65, I'm kind of saying like, okay, where are we at? Are we on an oral? Should we consider a transdermal? Should we try lowering the dose? How do you feel? But technically there's like no hard cutoff. I mean,
Okay.
Laura, I'll tell you, I had a patient in her 90s that came in on oral Premarin, asking for a refill. And I was like, I mean, at this point, you're 93, you've been on Premarin for 50 years. Who am I to take you off, right? But all of my colleagues were like, oh my God, she's on oral Premarin. I was like, she's been on oral Premarin for 50 years. She has no, like, look at her cardiology note. Like, everything is flawless, right? Like,
Yeah,
and again, this is not a general statement for anybody that you should be on it till 90, but like, all of that to say, like, every single year you should be reassessing what has happened in that year from a risk factor perspective. Like, are they up to date on their breast imaging? What are their cardiovascular risk factors? Have they changed in the last year? Has their family history changed in the last year? That sort of thing. So every single year when I see my patients, I sort of readdress where we're at clinically from a symptom perspective, but also like what has happened medically and in your family history in the last year that may make me want to like reconsider or adjust or change a formulation, right? Like a route of administration. I mean, that is a huge thing, right? Like different routes of administration of hormone therapy matter, right?
Absolutely.
There are certain things that are safer. There are certain things that may put you at a higher risk for things.
So what about the idea behind hormone therapy causes breast cancer or increases your risk of breast cancer? That is such a large, common concern of so many patients coming in.
Totally. Okay, so original numbers from the WHI basically said, okay, 25 to 26% increased risk for invasive breast cancer if you're on estrogen and progesterone, right?
Mm-hmm.
25% of already a very small number.
Yes.
All right. And that is what we need to be looking at these things in terms of absolute risk, right? Like, how does this
Mm-hmm.
clinically apply when you put it to a group of patients, right? So the number is an extra 1 case per 1,000 annually, or an extra 8 cases per 10,000 women annually.
Okay, so
Those numbers.
repeat that because
So I'll say
I
it in
want people to
two.
think about
Yes.
it. Yes.
Yes. An extra, if we want to talk in thousands, an extra 1 case per 1,000 annually. And if we think about it in a group of 10,000, extra 8 cases per 10,000.
So
And that is on
relatively
combined.
low risk.
Correct.
Yes, on combo hormone therapy.
Combo
Okay.
estrogen, progesterone.
Yes.
Here's the fun part. Women that were on estrogen by itself had lower risks of breast cancer. So this idea that like estrogen causes breast cancer clearly is not true if you look at it in the context of that, right?
Yeah.
I think from my perspective, I have a lot of, obviously I work in a breast center, right? So breast cancer is multifactorial, right? I don't think there's a single cause that causes it. The problem is if you develop it and 70% of them are estrogen sensitive and you're on estrogen, it's going to add fuel to the fire, right?
Yeah.
So prolonged exposure, could prolonged exposure increase your risk? It could slightly, but it's not much more different than obesity, being sedentary, drinking alcohol, and all of those lifestyle things that like we've talked about before, right? Those,
Yeah.
and nobody talks about like, I mean, and maybe we are starting to talk about some of those exercise and nutrition things that like we should be doing, but for a long time it was like hormones equal cancer, hormones equal cancer. I mean, just because you have a family history of breast cancer doesn't mean you can't safely take hormone therapy. I'd say go to somebody trusted and somebody that's practicing evidence-based medicine that cares about that, because you may qualify for additional breast imaging and you probably should in that case, right? So like, because estrogen can change your density. So chances are like if you aren't already dense, you probably will become dense, and therefore you should get something in addition to a mammogram. But like you can be followed for all of these things, right? Like it can be really individualized and it can really impact a woman's quality of life and like her self-worth. And similarly in my survivorship population, the women that unfortunately can't really take systemic estrogen, they're a population that we really need more data on. Right?
Yeah.
I think every woman should be able to make a well-informed decision on whether or not she wants to take hormones or not. She should understand the risks and benefits. She should look at the data. She should understand the data. Your provider should talk to you about the data. And you should ultimately be able to make that decision in conjunction with your doctor and your whole care team.
Yeah, that's such a good point. It's tailored so intimately with you, the patient.
Yeah.
And so it's important to not only bring these symptoms and concerns to your provider, but also know your family medical history. Because I get patients being like, I don't know, I have no idea. Now it's different if you're estranged from family, if you're adopted, if you don't know, that's okay. We can still make educated decisions based on your medical health. And then keep up with your screenings, people.
Yes.
So everything from breast cancer screening to cervical cancer screening, aka pap smears, colon cancer screening, there are guidelines that we follow. And just because you don't want to test your poop or have a small teeny tiny camera shoved up your butt, like these are life-saving, potentially life-saving, in general, minimal procedures. I think it's important to build a trusting relationship with your doctor. If you don't know the evidence, ask what the guidelines are. And now online, if you can look up anything from supplements to whatever you want, you can also look up these guidelines too yourself. The information is out there for you. So for many women, we had mentioned earlier that a lot of us docs have not been taught how to recognize or treat perimenopause, menopause, postmenopause, risk factors to look out for. How can women advocate for themselves in a medical system that maybe not only dismisses, but also just aren't educated about it?
Totally. So I would go to trusted websites. The Menopause Society website is a great resource for not only healthcare providers that want to learn more, but also for patients who are looking for somebody that's sort of like backed by this organization that has all certified. You know, you and I both sat for an exam to basically be a certified practitioner. And the bulk of that exam is basically knowing what the data has been for the last 25 years, right? Like, So it's not like a super easy basic test. Like you have to know the literature.
Yes,
And
it was
so
a hard
seeing
test.
some,
Can I just say
yeah,
that?
like, yeah, it wasn't easy, to be clear, right? Like I walked out and I was like, ooh,
I
I'm
wasn't sure
like,
either. I was like, I remember studying and I'm like, oh, this is all preventative care, primary care.
yeah,
I got
I
this.
got
I
this.
know a
Yeah,
lot of the guidelines already. There's a little bit of like the hormone stuff that I'm like, oh, I got to refresh this. But I walked out of
yeah.
that test and I was like, did I
Ooh,
don't there because it is a tailored approach, and
it
so
is.
you have to take multiple things into consideration. So yes, so find a menopause certified practitioner. That is
Correct.
public information on the Menopause Society website. You can
Yep.
also ask your doctor with their familiarity. Ask your OBGYN, ask your primary care doctor.
Yeah.
Anyone technically within the medical field could be menopause certified. So nurse practitioner is also, I believe, right?
Yep.
Correct me if
Yep.
I'm wrong.
There's a lot of nurse practitioners. Yep.
There are. And so also take into consideration that we have studied and read and took 5.5 million exams to get to where we are. The fact that
Yeah.
a lot of us are choosing to take
I know. That was a voluntary exam.
So we care. We care. We're
Yeah, we
interested.
care.
We are invested. So not to say that if your provider is not menopause certified, that they're not educated about it. So I think it's worthwhile to have a conversation with them. And, you know, most providers should be pretty honest about their answers. So what
I think
if
so.
a patient goes to their doctor and she is experiencing, I'm going to, again, use myself as an example, you know, I was having random palpitations, not really associated with exercise. I was suddenly constipated, again, not related to food. I wasn't sleeping well, which was also a new symptom. And I was achy. And so I go to my doctor, for example, and the doctor's like, okay, let's, you know, work up all of these symptoms. Everything is normal. You're okay. Just, you know, do some meditation. What, which I think a lot of patients actually, you know, do come back with as their response. What would you advise a patient like that in that scenario do? Like from a patient perspective, if their physician is not familiar with perimenopause, menopausal symptoms, and they're kind of fitting the picture, they've had all this objective testing that have excluded other causes. Would you advise them to switch to another doctor? Would you advise them to go up to the Menopause Society website and look up menopause practitioner?
I probably would, to be honest with you. If I wasn't able to actually see that patient and prescribe myself, right, or talk to them about it myself, I would say you need to go find somebody that can in your area and that could like really validate these symptoms, right? So like another part, like why I think we women don't really like talk about it is I think for decades they probably felt like really gaslit that their symptoms were like nothing and just like they were crazy and like, you know, okay, well you have joint pain and you have palpitations, okay, like we've ruled out cardiac disease and you don't have arthritis and like, you know, everything is good. So it'll get better, right? And then like it's hard because like you still have to find that doctor that you resonate with, right? It's like a relationship. You want to find somebody that like knows what they're doing. And I think a big issue in the menopause space, truthfully, is that women want to be heard, right? We always have been. I think everybody does, right? Women, regardless, right? People want to be heard and they want their symptoms to be validated. And when you go to a place that's not sort of your Western practice, right? Like you have the time to listen to a patient talk about their symptoms, right? And so women feel comfortable in that environment. And often, I'm not saying every time, oftentimes the person on the other end is probably trying to sell you something for cash and telling you that you need X, Y, and Z. And the reality is you probably don't need half of that stuff. And if you know, talk to somebody who is maybe like a certified practitioner, for example, like we'd be able to offer you the exact same thing that's covered by your insurance, to be clear.
We have a few minutes
You don't need all of this like, sorry.
No, that's totally fine. I think this is an important point that you brought up when it comes to vitamins and supplements in the last few minutes. You mentioned vitamin D earlier.
Yes.
What are vitamins and supplements that we actually do have a little bit of data behind or a lot of data behind that many of us should actually turn our attention to?
So yes, vitamin D3 for sure can help with immune health, bone health, mood changes, all of that. So I tell women like at least 2,000 units, like every single day. I prefer women to get calcium through their diet. If they're lactose intolerant and like can't do that, then calcium supplementation can be helpful. I have patients that are low in B12, maybe because they're vegan or from dietary changes. So if like you aren't getting a decent amount of animal protein, which is kind of the big dietary source for B12, sometimes they say go on a B12 supplement. I don't think there's any harm in taking extra fiber, in my opinion, right? Like if you're
Yes.
not getting it through your dietary goals, and again, to your point, like things are sort of like waxing and waning, and some of it can be hormonally mediated, like taking fiber, totally, or eating a
Yeah.
fiber-rich diet, totally. So those
Yeah.
are like the really big ones. I think magnesium can also be helpful
I
at
was going to
bedtime.
ask
It can
about
help with
that.
sleep. It can help with sleep. It can also help with mild to moderate hot flashes. So I like magnesium glycinate
Yeah.
in particular. But I would say those are really the big ones. I mean, you don't need all the other crazy things that, may tell you that you need it, but like
Agreed.
you don't.
Agreed.
You
Those are
really
the
don't.
few
It's a
things that
waste
I
of
counsel.
money.
I agree. Those are the few things that I counsel my own patients on. I take them myself. Magnesium glycinate has been a
Yeah.
game changer for my sleep and
Yep.
my night sweats. And they're all over the counter. You can buy them at bulk at Costco. Women, I
Yep.
mean, ladies, go to Costco, get your
Get ones
vitamins.
that are third party verified, right?
Yes,
Don't
that's
get
another thing. You're right. Yep,
like
that's a good point.
don't, because this whole industry is unregulated, so you have no idea what
You're
you're
right.
getting. So third party
You're
verified for
right.
sure. But really, those are the ones that you're gonna actually need. Like vitamin D is really hard to get through your diet. So like if you're
Yeah.
eating a healthy diet, chances are you're getting all of the other stuff through that.
Yeah, great point. If you could leave the listeners with one message about this very important transition period
I
of time
know.
in our lives, what would it be? Because we went through so many amazing things here.
I want women to know that they are not alone. And just because
Yeah.
they are feeling a certain way, they do not have to struggle through it. And that we need to change the conversation around this topic and hopefully make it more of a priority and truly an acknowledgement across cultures, across society, right? I mean,
Yeah.
in the workplace and medical research, right? So I
Yeah.
think my hope is that women know that they are not alone. If you're a provider and you want to learn more, feel free to reach out to me, reach out to Flora. Like we
Yeah.
have resources we can share with you, and like we're excited to share like the actual data. So like go to a trusted friend or resource. Like we all are working towards the same goal here. That's helping women feel really empowered in this next
Yes.
chapter of life.
Yes. And Sabrina, where can listeners find you online or if they happen to be in
Yeah.
Florida?
Oh, yes. I am on Instagram at Sabrina Sahni MD. I currently live in North Florida, so I'm at the Mayo Clinic in Jacksonville. We have a whole
Okay.
menopause, perimenopause department. We have
Love
a
that.
great breast center, so come see me.
Awesome. Sabrina, thank you so much for taking the time
Of
to,
course.
this is a very in-depth topic, and I think you did a wonderful job breaking it down, giving us a great overview. Hopefully, beyond listeners, you all learned something. If you can take a couple of things out of this, you can re-listen to it and take some more
Yes.
notes. You can bring these questions to your own doctor. And I think obviously we can't give personalized medical advice over social media, but I
Yep.
think it's worthwhile to follow and learn and then take those questions and concerns to your own medical provider. Dr. Sahni, thank you so much for being here. We appreciate you.
Thank you so much for having me.
All right, Beyond listeners, all of Dr. Sahni's information will be in the podcast information page. Thank you so much for being here. We appreciate you. I want to hear from you. Dr. Sahni wants to hear from you. So don't be afraid to DM any of us with questions, concerns, especially we can point you in the right direction. We will see you next time. Beyond listeners, bye. Thank you so much for joining and spending your precious time here with me. As someone who prioritizes her energy, I am so grateful that you chose to spend yours here. To help me help you, please take an extra 30 seconds of your time to rate and review the podcast on your listening platform. For more tips and a behind-the-scenes look into my life, follow me on Instagram at Dr. Flora Sinha. That's Dr. Flora Sinha. Finally, connecting with you truly fills my cup. So DM me on Instagram, email me at florasinhamd@gmail.com, repost if you love this episode. I love hearing from you. I am so grateful for you and cannot wait to be back for the next episode. Bye.